Hi, everybody. If everybody could start taking their seats, and if I can invite all of the panelists and the moderator for the Parkinson's disease movement disorder session to come on up here. We need Dr. Eisenberg, Dr. Krishna, Brian Fisk, Dr. Meng. Come on up. I hope you all enjoyed the break that was sponsored by Insight Tech. This is going to be our first kind of test panel with a hybrid session, so I'm going to introduce the moderator in a few seconds, and soon you'll also see our virtual panelists pop up on the back screen. So there's been a change in the program. Dr. Obeso, unfortunately, was not able to make his flight. There were some problems with that, so he's en route. Will be here live tomorrow. But we're very fortunate that Dr. Kaplan, who also has extensive experience with treating Parkinson's disease patients, is stepping up to be the moderator for this session. So I would like to formally invite him up here, and if we can get the virtual panelists to come on board. There we are. Awesome. This is all working, and we can get the introductions going. So Dr. Kaplan, the floor is yours.
Thank you. Thank you, Susie. So, yeah, it is my pleasure to fill in for Jose, who had some flight issues. I'm going to be showing his slides, if we can bring them up, and I will introduce our panelists for today. So in person, we have Vibhor Krishna, who was in the last panel from University of North Carolina, Chapel Hill. Howard Eisenberg from University of Maryland, who, as you heard from Graham Woodworth's talk, is really kind of one of the original pioneers of this in the US. Ying Meng from Sunnybrook, where obviously they have been, again, one of the pioneers in the world of this technology. And then virtually, we have Lloyd Zucker from the Florida Neuroscience Institute. We have Nora Venegas from the Baylor College of Medicine, and Brian Fisk from the Michael J. Fox Foundation, so obviously very important in Parkinson's research. If I can have the first set of slides up, please. The introductory slides. Okay. So, again, I'm going to try to get through this quickly. Dr. Obeso put some things in here that I think I'm just going to try to make some general points to lead to the introduction of the questions that we're going to try to address in this panel. So we all know, we've heard about this extensively, so we don't need to spend time on this, that there's high-frequency ultrasound for ablation, low-frequency ultrasound for blood-brain barrier opening. Why is it going? Okay. Now, for Parkinson's disease, we just heard about essential tremor. Parkinson's is a very different beast in many respects. So Parkinson's is a much more complex disorder. It's not just an isolated action tremor. We all know that Parkinson's has a variety of symptoms, and those symptoms may respond differently to different targets in the brain. So you're not talking about just one potential target. Functional neurosurgery has focused historically on the thalamus for tremor, but we know that treating tremor in Parkinson's with thalamic surgery often does not treat many of the other symptoms that are usually more disabling than the tremor to all but a minority of patients. And then you have the globus pallidus surgery, which can be effective for many of the symptoms, as well as subthalamic nucleus surgery, which is probably the most popular target worldwide, or certainly in North America, for deep brain stimulation for Parkinson's, although palatal deep brain stimulation at many of our centers has become more popular in recent years than it had been. And so you have these various symptoms of akinesia, rigidity, dystonia, often, as well as dyskinesia, which is the complication of medical therapy, and these targets can variably influence them. And also, whether deep brain stimulation versus lesioning actually lead to the same result in these cases is also a subject of equipoise as far as I'm concerned. And so we will hear from our panelists, for example, about the differences between treating tremor in Parkinson's and treating tremor in essential tremor, where thalamotomy is effective, but where the issues may be very different and the expectations may be different. And so you see here that we can do these various targets that I said with focused ultrasound. So you can do thalamotomy. Obeso and some others have been doing subthalamotomies, pallidotomies. But again, the local anatomy is part of what governs the safety profile, and these are very high rent districts. They're very tight targets that you have to be very careful when you're doing lesions, and they are heterogeneous structures. So whether a lesion within the pallidum, let's say, or even the subthalamic nucleus, whether you want to lesion the whole thing or just part of it, and by lesioning part of it, are you going to get more tremor effects, or are you going to get more dyskinesia effects, or more rigidity? And are you going to affect cognitive issues, particularly in the STN, where there are affective and cognitive components of the STN in addition to the motor components? These are all things that remain to be seen and that need to be debated. And then, this is his thing. Let's see what comes after this. So this is similar things about all the various studies on these. There is finally the pallidothalamic tract connects, as the name implies, the pallidum to the thalamus. It is a more midline target, as those pallidothalamic fibers pass sort of medial to the internal capsule and the thalamus, just lateral to the mammillothalamic tract. And so that is a technically easier target to hit with ultrasound because it's more midline. But again, there are very important structures for learning and memory medial to it, as well as the internal capsule lateral to it. And so there is an ongoing study based on pilot data of bilateral pallidothalamic tractotomy that we are all doing. You know, we've heard similar issues to what you heard before about using fiber tracking, et cetera, for improving your targeting. But the thing with Parkinson's that I think, you know, from a research standpoint is potentially most cutting edge is the ability to use blood-brain barrier disruption, as you heard a bit of this morning from a research standpoint, to use the low-frequency device to open the blood-brain barrier, both to potentially clear pathology, as we'll hear a lot more about in the next session for Alzheimer's disease, as well as to deliver things. So things like gene therapy, which has been a research interest of mine for over 30 years, and we've done we did the first Parkinson's gene therapies in human patients with direct injection. But, you know, the ideal would be to deliver this non-invasively, but there are a lot of challenges there. And so you can do this in human subjects, and Jose has done this in a pilot study for cognitive dysfunction in Parkinson's, and this has been published to do blood-brain barrier disruption safely, and this is stop moving forward. So I think, but the question is, can we deliver things? He's been doing this in primates, as have we. So many of us, as you heard this morning, have been doing this in rodents to deliver, for example, gene therapy agents. But even though you can get good blood-brain barrier disruption in primates, you don't see a lot of cells. Here's a few cells that he's seen. We've seen similar, that in primates it is not nearly as easy as we've seen in rodents to get good gene delivery. And it's not simply a matter of amount or volume. There are other factors that we need to work out that may be relevant to humans. So blood-brain barrier disruption and delivery, just because you get gadolinium enhancement does not necessarily mean you're going to deliver the same thing every time, regardless of what type of agent it is. A drug, a gene therapeutic, a virus, an antibody, a cell. They're not all the same, and so these are things we all have to work out. And so some of the challenges that I think we want to discuss in this panel are, what are the most appropriate targets for different clinical manifestations of Parkinson's, motor, dyskinesia, dementia, et cetera? What are the biggest advantages and disadvantages of focused ultrasound to treat Parkinson's specifically? How we should progress with this blood-brain barrier opening for neurorestorative therapies, and what can be done to promote the clinical applicability in PD and other degenerative diseases. So with that, I'm going to move to the panel, and I think I'll just go in order of the names here. So I think our first speaker will be Lloyd Zucker from the Florida Institute, Neuroscience Institute, which is virtual. And do you have, I think you do have slides. Can we bring those, do those just come up? Oh, there we go. Okay, so here are your slides. I will click for you.
Go ahead. Actually, if you click through, it'd probably be easier with a full slide. So basically, you know, first of all, thanks to the foundation, Dr. Kaplan, thank you for leading our group. Where you have gone, I think, is one of the most important things, and that is really how do we define, you know, patient selection and target selection. And so I'm going to put forth a slightly different paradigm. The top part of the slide is basically the way that we've done things by classifying our patients by basically clinical scales and the diseases themselves. Where we've headed is a slightly different way. There has been a fair amount of work on the Human Connectome project, and we're trying to propose that by looking at both structural and functional differences between controls and disease states, whether it be Parkinson's, essential tremor, Alzheimer's, you name it, that there are at the structural and functional levels differences in their connectomes. And when those things are combined with machine-based learning, you can basically tease out the anomalies and the location of the anomalies between those patient groups. And by using those anomalies, then decide from a neuromodulation point of view which way you would like to head in terms of modulating the circuit. So if you could go to, I believe, the next slide. Basically, you have a situation where you have a fairly large scale of normals, and that way you develop the connectomes for those normals, and in a simplistic sense, you're overlaying the connectomes both functionally and structurally from the disease state and processing it with a machine learning algorithm. And you can basically tease out many different things. You can tease out following disease, you can tease out targets, you can tease out treatment paradigms, you can tease out target selection. So that is a little bit different than the standard stereotactic targeting that we all know and love and have used for many, many years. And so we're basically looking for intercorrelation between different brain areas. And if you go quickly to the next slide, there's just kind of a schematic of what I'm talking about. So those are the parcellations of the different areas of the brain, and what the matrices that you saw are looking at the correlations between the brain networks. And the proposal is that some of these networks are hypoattenuated, some are hyperattenuated, and by using the Human Connectome project and the 180 parcellations that we now believe exist, you can see areas of the brain that are more tightly correlated than normal, areas of the brain that are less tightly correlated, and then areas of the brain that are basically null factors, and utilize those areas to try and understand which areas are under or over communicating. The black are basically noise areas. And by using those areas of brain connectivity, go after those areas with some aspect of neuromodulation. As Dr. Kaplan said, whether it's deep brain stimulation, whether it's focused ultrasound. So hopefully that gives us a basis of a slightly different way to look at both the disease and the treatment paradigm. So I'll turn this back over to Dr. Kaplan and go from there.
Hey, thanks very much. Next, Howard Eisenberg.
Yes, good morning. Thanks to the foundation. I'm going to talk briefly about bilateral treatment. Obviously, this is of great practical importance in these diseases, and this is more or less briefly the pathway that we've taken. So I know the last session was about tremor, but and Michael gave you a glimpse of the trial that has been completed, and now we're in the process of thinking about publication. And he showed you some of those data. So without giving away too much more of the detail at this point. All of these meetings, when it comes to discussion of publications, end up the same way. It's what to shoot for, what journal would we go for, and the three of us that met said high impact, so I'll leave it at there. Then we at the same time, we did a unilateral, which I think appeared in one of the last few slides, of Parkinson's, using the target was the pallidum, and that included 96 patients, not on this slide, by the way, 96 patients. It had a placebo, but for this kind of a treatment, placebo is definitely a problem because the effect of treatment is usually immediate. It's a placebo-controlled, multi-centered study, 96 patients. Those data, we've started to write the paper, Vibor and I, and submitted it, and it's going through the process of review. After a long period, we've sort of become optimistic that this will get published in a really good journal, but we don't know that. So we thought, having done that the next step would be a bilateral GPI study. The issue, obviously, is not just efficacy, but really safety. And when Insightec met with the FDA, they were persuaded by the work that's been done in Switzerland, and we went to this other target, bilateral pallidothalamic tract, as a target. That study is ongoing. Can you back up just for a second? Thanks. And you can see the entry criteria, and randomized, let's say 50 to 60 patients. You can see the outcome, the follow-up. The primary outcome is 3 months, just like the ET study, but the patients will be followed for 5 years. So all of the patients, all 50, I think it's a little over 50, have been treated on one side, and now we're moving to treat the opposite side. And it's staged, just like the ET study was staged, 6 months between treatments. So the study is on hold so that the FDA can look at the outcome of the first 10 patients treated bilaterally, and we think we'll then be able to, because we don't know, think we'll be able to restart the study maybe even before the new year. So that's an ongoing study. And then you can show the next slide. So next slide talks about, so what is the target for this this study and the studies that were done in Switzerland? And you can see the anatomic diagram on the left side. It's a very narrow target with a lot of possibilities for overlap. And the question was how to target this. And I think people in this study have used other ideas about where to put the target. But what we've done is the issue is really to avoid any heating up the mammillothalamic tract. So at the mid-commissural point, at the ACPC level, we moved laterally, and we were equidistant between that point, that is the mammillothalamic tract, and the internal capsule. And then what we did, assuming that we got a good result at the primary target, we moved more or less parallel to the internal capsule and created a series of small lesions in that direction, going posteriorly. And the idea, although I don't know that there's real data to support it, is that if you do that, there's less likelihood of recurrent tremor, which would be hard to treat. So just to summarize where we're at now, patients have been initially treated. We're going on to the second stage. 10 patients have been treated bilaterally, and we're just waiting to look at the outcome of those 10 patients, particularly with regard to balance and speech, and then proceed. So we're very optimistic that this will just be temporary and we'll move on, and then we'll see what we find. Thanks.
Okay, thanks very much. Vibor.
Thank you for the foundation for the opportunity to present our work. So as continuing the sort of theme from the last panel discussion, we are passionate about optimizing this treatment. And the idea is we want to reduce the heterogeneity in outcomes. And as Dr. Caplet raised the point about reducing the risk of recurrence, we thought to approach this by optimizing the treatment using DTI to identify target in patients with essential tremor and Parkinson's disease, and to deliver ablation in a standardized way. Next slide, please. And next slide, please. So this is the conceptual model, and if you go next slide, please. And so go back one more, sir. And one more. So in the standard workflow for focused ultrasound ablation today, we all go through three steps. Planning for the surgery, where we come up with stereotactic coordinates to localize target in each patient. We deliver treatment, ablation, and as you heard, sometimes we deliver one ablation, sometimes we deliver two ablations. And then we have these intraoperative tools with thermography to monitor temperature, understand how much thermal dose is delivered. And the idea is that the current methods for stereotactic targeting use indirect coordinates, indirect visualization, either through the formulaic methods or use 2D atlases to superimpose on patients' MRI. And then when we go to the treatment, as you heard, one of the astute questions from the audience is, when do you know when to stop? Currently, we don't. We don't have a standardized way to pre-specify a volume of ablation or number of sonications. And as we saw, that intraoperative tremor during the ablative stages is unreliable. And so your tremor suppression is much significant during the treatment because you're having a combined effect of ablation, partial ablation, and thermal neuromodulation. And finally, thermography, even though it's very helpful for immediate feedback and for temperature monitoring, for calculating thermal dose, we know that there are shifts in MR thermography. And so the location where the software shows you where you're ablating may not be the actual site for ablation. And so these three sources of error create a discrepancy between where we want to ablate versus where we end up in ablating. And so the overlap between ablation and your presumed target is not as accurate as we think. And so can you go next slide, please? With tractography, the idea is to visualize VIM. We are not after the DRTT. We are after VIM. We want to localize the three-dimensional volume of VIM in relation to the pyramidal tract, in relation to the medial lemniscus. And as we go to the operating room, we pre-specify a volume of ablation. And so in this case, we say 70% or more of the VIM volume. And then we implement intraoperative imaging beyond MR thermography to identify what volume of tissue has been ablated so that we can maximize the overlap between the tissue that's ablated and tissue that we want to ablate in each patient. Next slide, please. And so these are the two examples you can see on the left. In A, we are showing the VIM with this ROI that is white in color. And then inside that is the thermal dose overlay. And as you can see that in this case in A, the thermal dose overlap doesn't cover all of the VIM. So potentially we are in a situation here where we are under-treating this patient. In B is the overlay that extends beyond the margins of VIM, and so potentially creating a situation where you're over-treating. So you are even spilling over into the adjacent areas for the VIM. And so this is a condition that you would potentially want to avoid. We want to be somewhere in the middle. And what we observed is, next slide, please, that once you start to, we'll go to the next slide, please. When you take the VIM ROI intraoperatively for active monitoring and active guidance, you have a situation where you know how much volume of VIM you have ablated, and potentially get to a point where you standardize and on a consistent basis ablate a certain volume of VIM. And so the bar graph shows you that when we had the standard approach for focused ultrasound ablation, the volume that we were ablating of the VIM varied quite a bit. The confidence intervals are wide. And the actual volume that we thought we were ablating, actually we ended up in only ablating 40% of the VIM. And as we had the ROI intraoperatively, and we actively decided to go after a certain standardized volume, the confidence intervals are tighter, and we are able to get to higher volume of VIM ablation. So at the end, combining the location and the lesion volume in this target overlap to deliver a standardized VIM ablation and hopefully for more homogeneous outcomes in future. Thank you.
Thank you very much. And now, Brian Fisk from the Michael J. Fox Foundation, who will join us virtually.
Hi, I think I have an intro slide if you, there we go. Yeah, so I'm Brian Fisk. I'm Co-Chief Science Officer at the Michael J. Fox Foundation. I'm guessing many of you in the room probably know who we are. For those who are maybe less familiar, we are a research foundation founded in 2000 by the actor Michael J. Fox, who lives with Parkinson's disease. We are a global strategic funder and facilitator of research and drug development for Parkinson's, with a research agenda that really focuses on kind of a broad suite of focus areas, really driven by the idea of how can we better define, measure, and ultimately treat Parkinson's disease. And through our strategic funding programs and other activities, we really try to move the needle in these areas. If you move to the next slide. Is when it comes to focused ultrasound, this is, for us, one of, I think, many, obviously different options for thinking about treatment for Parkinson's disease, and in an area that we've put some funding support over the years to help kind of bring it and position it as a potential treatment for the disease. Some of our earliest funding actually was to support some of the early trials exploring, in this case, its use in addressing dyskinesia in Parkinson's disease. Some of the early trial work there that actually ultimately helped support and I think bring it to its more recent approval for fluctuations and dyskinesias in Parkinson's disease. For us, more recently, it's been an interesting, it was mentioned earlier about sort of the role of using focused ultrasound and sort of opening blood-brain barrier, either as obviously a drug delivery opportunity, but for us, some interesting exploration we've been doing, actually looking with investigators down in Texas, exploring its potential use as sort of a non-invasive brain biopsy. So how can we sort of detect biochemistry in the brain non-invasively as a way for exploring different types of biomarkers and other kinds of measurements about disease progression and disease process. So that's been sort of an interesting application in our view of using this technique. We've also, like we do with many treatments, certainly available treatments for Parkinson's, we try to make sure we can help educate and build awareness for the Parkinson's community. So we have a number of sort of awareness and education materials, trying to help people understand what focused ultrasound is, how it's sort of currently being used in Parkinson's, and sort of help guide them in their discussions with their doctors about its availability and its sort of options as compared to, say, deep brain stimulation and other types of approaches that may be available to them. So important for us to kind of put these types of treatments in a perspective that can help patients make better decisions about their care. So we've worked with the Focus Ultrasound Foundation through a lot of this work. So it's been a great collaboration to be able to do that, and a great way for two foundations to come together around an important area like this. So something that we hope to continue to work together around as we continue to explore this really interesting technology. And I'll stop there.
Thank you very much, Brian. So our last two speakers don't have slides, but I'll ask Nora Venegas, who's joining virtually, if she has anything to add. What happened?
Yes.
Oh, we lost our screens for a second. Sorry. Why don't you go ahead, Nora?
Yes, good morning, and thank you for the invitation to this panel. Just briefly, I'm a movement disorders neurologist at Baylor, and my clinical and research work are focused on neuromodulation, including deep brain stimulation, focused ultrasound, and also I'm part of the focused ultrasound brain biopsy initiative. I do not have slides because my intervention is more of an invitation to the focused ultrasound and Parkinson's disease community to work together on patient selection criteria. I believe that despite the well-described benefits of lesion therapy using MR-guided focused ultrasound for tremor and other aspects of PD, which Dr. Kaplan very nicely delineated today, there is a clear variability of clinical outcomes and particularly adverse events across studies and across teams. I believe that the patient selection criteria are heterogeneous, particularly based on the level of comfort of the teams, and this likely reflects a steep learning curve for new teams that are coming to offer this type of therapy. And there are only a few studies examining predictors of treatment efficacy, but mainly for the treatment of essential tremor and primarily focusing on targeting and ablation techniques, but less so on disease features and how phenomenology could influence outcomes and adverse events. So while patient selection criteria will invariably evolve as more experience continues to be accumulated, I believe that a consensus of patient characteristics and recommendations for pre-procedure assessment leading to safer and more effective outcomes is a major need of this growing therapeutic modality. So my input is primarily an invitation to our focused ultrasound community to consolidate Parkinson's disease patient selection criteria based on the limited current evidence. And I think that in addition to better informing the teams newly adopting focused ultrasound for the treatment of Parkinson's, this will help us better characterize our patients going forward and further improve the delivery of this therapy. I would love to hear, if we have time, any opinions in regards to barriers, opportunities, and lessons learned from other modalities where we did this, such as the brain stimulation.
Okay, thank you very much. And before I introduce our last panelist, I just want to remind those who are attending virtually that if you have questions, please post them online. We encourage them, and I should have access to them here, and we'll read them appropriately. And so our last panelist, Yi Meng from Sunnybrook. Also, I don't think you have slides, but I'll ask you to say a few words. Thanks.
Thank you for the invitation to be part of this panel. I'm Ying. I work with Dr. Lipsman and Dr. Sunil Kalia and Dr. Lauren Kalia on this study that was recently published for I guess I was invited to this panel for. I work mostly in the space of blood-brain barrier opening and worked in the initial study with Alzheimer's and as well as brain tumors. And more recently, we looked to patients with Parkinson's disease. And in doing so, we thought about combining focused ultrasound blood-brain barrier opening with a therapeutic as we felt the field was moving towards delivery as opposed to just blood-brain barrier opening. In that, we look to patients with GBA mutation, PD. This is a mutation that predisposes patients to develop Parkinson's, and enzyme replacement therapy is a potential treatment for this. So recombinant glucocerebrosidase with GCase, it's a available drug for patients with double mutation of GBA who have Gaucher's disease. And we thought because this was readily available and its safety profile is very good, that it would be a reasonable option and with scientific background to it to combine it with focused ultrasound in patients with GBA PD. So we pilot trialed this study in 4 patients, and results were published recently. The results were quite simple. The patients tolerated the procedure with combination of these 2 therapies quite well. And moving forward, we're looking at doing this in expanded number of patients and looking at more treatment outcome markers.
Okay, thank you very much. So thanks to all the panelists for getting us on time. And so we have quite a bit of time now for questions. I'll open up first to the floor. Are there any questions for the panel from the floor? And while I do that, I'm going to see if there's anything online. And if not, I'm going to just throw out to the panel a few questions, and then I'll ask if the panel also has any questions. So one question I have, oh, please, go ahead, sorry.
So in deep brain stimulation, one of the things that people are looking at more and more is multi-target stimulation. And I'm wondering what the panel thinks about multi-target focused ultrasound ablation and or combination of blood-brain barrier opening with drug delivery and ablation at the same time. I know this is sort of the advancement, but we're supposed to be talking about the future here. If anyone had any thoughts or on that.
One of the problems with doing something complicated is getting approval to do it, and that adds a whole dimension of issues. But so I think what we're looking at now is ablation, right? And it'll take a while to get, if that works, and safe, obviously, we'll get that approved. But that's sort of back to the future that's been said, I think, in the last panel, and that we all realized that. So the future probably is the blood-brain barrier and treatment by getting important molecules into the target, and that might solve some of the problems of some of these complications. We don't know, but I think that would be the direction. Whether some combined effort at targeting, hitting one target with an ablation and then moving or doing a second procedure, possibly even at the same time, to get an important molecule in, it could be interesting. But this has to be. I shouldn't say this. What do I know about the FDA? I mean, it would be, I think, a tough sell it would take a while, I think, to go in that direction. But you might be right. I mean, who knows? We're just sort of starting out. But I think we need to, if we can, get ablation approved and funded by CMS. So two separate hurdles to get over, and then while that's going on, look at, I think what's going on in Toronto, and we're very interested, possibly collaborating, is this genetic connection with Gaucher's and Parkinson's, and trying to attack it in that way seems very intriguing. So, and then of course there are a lot of other ways of looking at what you could do with opening the blood-brain barrier. So I think that's the future. That's where our imagination is going.
I would add that one of the most exciting things, in my opinion, about the human studies to date with blood-brain barrier disruption is less about the outcomes, because not surprisingly, they've been modest and this is early days. But the fact that we can take a degenerated brain, whether it's in Alzheimer's, as you'll hear in the next session, or in Parkinson's patients, et cetera, and do this multiple times over a period of weeks or months, without causing major decline, raises the potential that you can deliver different things to different parts of the brain and really reconstitute circuits, right? So we've been doing this in animals where we deliver a gene to one area of the brain in Parkinson's models, wait for the blood-brain barrier to close down, and then a week or two later, deliver a different gene to a different area, because you can't do that when you open the blood-brain barrier initially, right? And so the fact that in humans that is feasible allows us to at least speculate and think about the possibility of really reconstituting circuits using different molecules, different cells, different genes, different whatever, to different areas of the brain, because we've shown feasibility in humans. So I think that's very interesting.
So I'll take a little part of this in the ablation realm. And so far, multi-site or site-specific improvements in the DBS realm were limited because there is a trajectory to DBS. And so you wouldn't know what part of pallidum outside of the trajectory would somehow give you improvement in dyskinesia versus improvement in dystonia or fluctuations. And so I think Mike said it in the previous session, focused ultrasound is an ideal modality to sort of interrogate different circuits and then see their clinical response. And to this point of collaborative efforts nationwide, where we could understand what are the different therapeutic areas and their site-specific symptom improvements is an exciting area, at least in the ablation realm.
So we have an online question that I'll ask before we go to our next in-person question. So from Zachary Levine, he asked, DTI is center to center and MRI to MRI inconsistent. Does this affect targeting? And I think it's an important question because I think we all struggle with this. We're big proponents of DTI as well, but even patient to patient, I'll talk with my radiologist, sometimes we're a little more confident than others in how accurate it is, et cetera. It's very dependent on the user and the machine. So the question is whether it's DTI or whether it's some of the stuff that Lloyd talked about with networks and MRI, et cetera. These things can be great in groups, but how confident are we that they are sufficiently predictive on the individual basis to really be relied upon?
That's a great question, Dr. Caplet, and I'll say that there are centers who know how to do it, and they do it well. And the idea is to take that experience and replicate it. And I didn't realize the significance of it till I came to UNC, and so now I'm getting used to a new protocol, new sets of machines, new sets of technologies, and new ways of doing the MRI, and I'm still not 100% confident in my own tractography protocol, whether this will localize it or not, and so it'll take some more work. So your point is very well taken, that the results vary depending on what machine people are using, how good they are in terms of padding the patient's head so that they're not having a lot of head movement, and what software you're using. And so there are clinically approved 2 or 3 software, and each one of those have limitations. And so we have to have, as a group, a discussion as to what will it take for us to accept that DTI is sufficiently accurate to give us the results. Say, for example, Dr. Caplet, you mentioned that in your center, the way you target is you have an independent clinician who identifies the target, and you have your own way of identifying the target. So something similar to that, can it be tried in DTI realm, where we do 100 patients prospectively, and then comes, there is a DTI target, and you choose your own target, and if the concordance is more than, say, 90-95%, then we start to trust the DTI. And so I agree that a lot of work needs to be done in optimizing this, and understanding what it takes to optimize it in specific centers, and do that with high accuracy.
Thanks. So we have about 10 minutes left in the session. I want to try to get as many questions in as we can, so I will go to Dr. Cosgrove next.
So prior to the advent of DBS, stereotactic radiofrequency pallidotomy was one of the best operations and enduring operations for people with Parkinson's disease, at least in my experience, and I think in the world experience. We now can do stereotactic MR-guided focused ultrasound pallidotomy, but all 3 of the neurosurgeons on this panel, what's your opinion on pallidotomy target using focused ultrasound versus the PTT versus maybe STN? Do you guys, you've all done PTT targeting, so I'd just like to get your opinions on that.
Well, Howard, you've probably done more palatal ultrasound than anyone, so I'll let you start.
I think you've done more cases than I have, but I was very skeptical when we switched from GPR. I thought that was the path that we were going to take. But actually, unilateral, which is all we really know about, it actually works, I think, works out pretty well. We had one patient initially of the group that we treated where we didn't get a good result, but I think we were too timid, and we didn't use enough energy. After that, I think we got good results unilateral.
With PTT?
With PTT, I'm sorry.
So
yes.
your preference is PTT over GPI?
Well,
putting you on the spot.
I'm being guided by. Yeah, I personally, I would say the jury's still out right now, but I will say, to Howard's point, it is an ongoing study, but we have at least a couple of patients that are not necessarily going on to the other side because they're doing so well from the first side. So I think, it may, but that may be very patient-specific, right? These are ends of 1 or 2, so.
The other thing is we always get midway MR scans both for all our targets, actually, but particularly when there's a long cool down period and we have plenty of time to get more imagery. Basing our targeting on tractography hasn't worked out as well as I had hoped, and maybe that still needs more work, and it should work, right? I mean, why aren't we? So sometimes the tract and what we think is the target and what proves to be a good target are not all that close. Sometimes the tract seems too far back, too close to the posterior commissure, for example.
There's a question over on this side, sorry.
Yeah, hi, Mike. If we're thinking about enzyme replacement therapy here, why aren't we thinking about cell replacement therapy? I mean, we've been doing cell transplantation and for a while in Parkinson's disease, and where do you see a role of BBB opening and potential cell replacement therapy in order to improve conditions for the patient?
I think that's a great question. I think a lot of that answer to that question is the practicalities of the idea. I think Dr. Albert's lab have looked at cell replacement therapy for Alzheimer's, and we kind of conceptualized that kind of study for the clinical trial. We would have to, for instance, insert an intraarterial line for the injection of the cell therapy, and at the same time, that would have to be MR compatible, and they have to be in the suite. So there's a lot of practical challenges to that kind of study, but it's something that people are, conceptualizing as well.
Yeah, I mean, I think it's been well shown in several groups that you can deliver cells with this safely. So, and I did mention it several times in my introduction that it is something that I think many of us are interested in. It's a challenge because one of the things that we haven't talked about, whether it's gene delivery, cell replacement, et cetera, when you're giving this systemically, those things go elsewhere, right? And so these are challenges that we have to address, but it's an absolutely viable and important area. We have another question online. Sorry, Jen, I'll get to you next, but we have another online question. So the question from Amine Akpinar, I hope I pronounced that correctly, is you said that artificial intelligence techniques such as machine learning can be used in patient selection. Is there an AI system that you've developed and used in real-time applications? So I'll throw that, I guess, to Lloyd, who's the one who mentioned this.
Well, actually, there is not a commercially available AI system. There are AI systems that have been utilized in the Alzheimer's domain and have been partially vetted. I don't think in the Parkinson's arena that there is a vetted AI approach, but part of what we're actually trying to do is to utilize that. And speaking to Dr. Krishna's approach, part of the variability between sites and between machines may actually be able to be removed if everybody has access to the same AI technology. So it's kind of tantalizing that we can, either intentionally or unintentionally break down one of those silos between centers by having a common technology. It's that future that everybody is talking about, but at the present point in time, there is not a commercially available AI.
Dr. Chang.
Okay, when I first underwent the pallidotomy with ultrasound, I was trying to make a bigger lesion as we did for RF pallidotomy, but I had many difficult cases, especially because of the Asian scar. I want to know your opinion about the optimal size of the pallidal lesion with ultrasound. Sometimes some people want to make it just a single lesion like the thalamotomy, but some people want to make additional bigger lesion like we did for RF pallidotomy. But there's no consensus, but to my point of view and in my experience, if we make a bigger lesion like RF, seems like more sustained benefit.
That's a great question, Dr. Chang. And I'll start off by saying that the pallidotomy lesions seem to be limited by the technical ability to ablate in the pallidum, patient skull, and patient tolerability. So most of the treatments that we did with pallidotomy, it ended up in being to a point where patient had too much pain or they couldn't tolerate any further. I wish we had ways to make heating more efficient in the pallidum and start to address this question, because I agree with you that that the size of lesion that we would all want to make in pallidum in focused ultrasound treatments would be larger than what we are making right now.
Yeah, I mean, I would say that you're right. I don't know what the right size lesion is. I'm much more concerned, frankly, about where my lesion is because, you know, obviously medially you have the capsule, right? But I'm also concerned laterally about getting into the GPE. You know, sometimes I think you get away with it in a very severe patient where their GPE isn't doing very much, but in a patient who's not quite as severe, you could really hurt them by getting to the GP, right? And then if you start to put on a mask that narrows it down, you're going to drive it down, and what's down is the optic tract, right? So we're talking about a very, very tough thing to measure there. So I mean, for me, I don't know what the right size lesion is, but I know what I don't want to do. One thing I think is important to mention, for our Parkinson's cases, much more so than our tremor cases, we mark out additional areas for thermometry. I think it's critical because you don't get three-dimensional information, right? When you're getting your thermometry, you only get two-dimensional information. But if you can watch the heat curve in the areas that you're concerned about, so for the pallidum, right, we'll mark out the optic tract. For the PTT, we're particularly concerned about the mammillothalamic tract because I can tell if a patient's starting to get a little dysarthria or something on the capsule, but I don't know what's going to happen to their memory if I get into that MTT. And the other, I think, trick is that you don't necessarily want to mark out the whole thing. You really want to mark out the edge of it that's closest to where you are. So the lateral edge of the MTT, right? The superior edge of the optic tract. So you're measuring, you know, what's going on just as you get into it. I think for now, at least, those are the critical things to avoid problems while we figure out what the right lesion is.
We might be helped by better three-dimensional thermography than what we have now. And the other question is in the pallidum, of course the pallidum is lateral, so it's harder to, just as you were inferring. But so when we expand a lesion in VIM, they're usually contiguous. You know, we move slightly and make it larger, but is that the right thing to do in the pallidum? Or are we hitting two separate targets that are close together? I don't know the answer.
I'm not sure we have the answer, but I'm going to leave that hanging out there because I'm being told we have to finish. So, but I want to thank all the panelists virtually and in person, and thank you for the foundation.
Thank you. That was a fantastic panel, and I hope it's inspiring all of you to think of the next research projects to help advance the field and move forward.